Welcome everybody, it's Nick here from Open Door Coaching. Thanks for joining us today for our Coaching Cafe, where we're looking at recognising the signs of anxiety and depression in the workplace. A little half-hour session for us today. Let's get started. First, we'd like to acknowledge the traditional owners and the custodians of the lands which we're meeting on today. And we'd like to acknowledge the continuing connection to the land, the water and the communities of Australia. We'd also like to pay our respects to them and to their elders past, present and emerging. All right, little half-hour session today for our weekly Coaching Cafe webinar. Bit of a packed agenda, but we're going to cover some facts and stats. It's a hard thing to say. Some facts about mental illness, mental health, however we like to refer to it here. We're going to look at some basic statistics for you, show you some of those. We're going to have a bit of a in-depth look at depression and anxiety. And in particular, we're going to focus on the signs we might see in somebody that is experiencing these things so that we can then have a conversation with them and support them, which is the third part. We're going to give you our tips here about how to have this conversation. And I can see from the list of attendees, we've got some of our mental health first aid students on the line as well. So yeah, it's really great to see you all back. So really these coaching cafes are about creating a bit of a sense of community for leaders and managers and coaches. And we're really sharing our learning. And so part of that obviously is for you all to also share what your thoughts are and your inputs on the topic too. So we like to have these sorts of conversations, if you like, on these webinars. So feel free to pop your hand up and throw questions at me through the chat or the Q&A. I really love that sort of style of conversation, particularly around these sorts of topics around mental health. Now, if you are a credentialed coach with the ICF, this session will earn you a CCE points. So I will drop the CCE certificate into the chat box right at the end before we finish up. So hang around to grab that. So before we get started, if you've got a question in mind about mental health or anxiety or depression or any of these sorts of topics that you're coming here, yeah, come along and into the chat box and open it up. All right, so in Australia, 1 in 5 Australian adults experience a mental illness every year. So it's 1 in 5, that's 20% of us experience a mental illness every year. So it's quite a large number. And there was some interesting research out towards the end of 2020 that was suggesting that this number was somewhere around the 3 in 5. Obviously, with all the goings on with the pandemic and all the impacts that that's had, our mental health was affected greatly. And some of that that is represented in that early research. So if we think about it as 1 in 5 as a baseline, the bare minimum, and we operate on a basis that it's probably more like 3 at the moment, I think that gives us a really good sense of the depth of this issue here in Australia, that we have this level of prevalence around mental health and mental illness. And out of those 1 in 5 or the 3 in 5, the vast majority of them, 65%, don't actually get any professional help for their mental health. Now, this is a big problem for a lot of reasons, but the main one is that we know that people experience the greatest relief and the relief from suffering and recovery when they are connected to professional help. So having this stat here sitting at 65% of people not getting it is a really big issue. Yeah, it's a really big issue for those people. And then the more we have in terms of the 1 in 5 or the 3 in 5, then the bigger that issue becomes. So we need to get really skilled up in terms of how to spot the signs and how to have a conversation with somebody about their mental health. These are the bare stats. And a lot of people, when they see these stats, are quite shocked by them. Yeah, they're quite surprised, or maybe alarmed is a word I heard the other day, that it was 65% of people don't get professional help. So let me know in the chat what you think about that. So I think if we're going to be talking about mental health and mental illness, then we really need to think about what mental health and mental illness is. And the best way to think about this is that it's a continuum. So our mental health is a continuum where at one end on the left there, we have poor mental health or mental illness. And on the other end of the continuum, we have excellent mental health. It's a continuum. And if I asked you all to draw on this diagram here where your mental health currently is, you might be where the pointer's pointing, you might be somewhere else on the continuum. And this is the normal human condition. You know, we're all at different points of the mental health continuum at different parts of our life and of our day and our week and so on and so forth. And we go up and down. Yeah. And particularly if I asked you yesterday or tomorrow or a year ago where your mental health was, it would probably be somewhere different. So it's normal to go up and down the continuum here. Yeah, absolutely normal. And it can happen for all sorts of reasons. It can happen because things happen to us. You know, we might have experiences or trauma, these sorts of things. It can happen because of our biology. You know, what's our biology doing? How much access do we have to support? You know, our financial status, all sorts of things can affect where we sit on the continuum at any one time. And importantly, how well we are able to move back towards the green zone on the continuum when we're not in the green zone. So if it's normal to go up and down this continuum, yeah, let me know what you think about that in the chat. Carol says it's shocking in the workplace is an antecedent of mental health issues, workload, politics, etc. Yeah, certainly workplace pressures can have an effect on our mental health. Absolutely, it absolutely can. And as we know, you know, people don't just leave all their personal stuff at home or at the office when they leave the office. We are human beings and we exist in multiple places. You know, we have a work self and a home self. And, you know, we carry all of that stuff around with us. So you're absolutely right. The risk factors that underpin people moving into the yellow or the orange or the red zone here on the continuum are broad, and a lot of them are present in workplaces, and particularly over the last 12 months or so with the pandemic. You know, work has changed. So yes, I absolutely agree. Workplace focus on mental health and mental well-being is absolutely critical. So let's have a look at the two most common mental illnesses in Australia, and they are depression and anxiety. Before we go on, can you tell me in the chat box, is it men or women who experience the higher rates of mental illness in Australia? Is it men or women? You can type in men or women or M or F or whatever you like. Is it men or women that have the higher rates of mental illness in Australia? I'm looking at all the people who've done mental health first aid on the line, looking to see what your answer is. All right. So we've got a bit of a mixed bag. I think it's slightly leaning towards men in the chat box. And yeah, this is what normally happens. Groups do report that they think that it's men who have the higher rates of mental illness in Australia, but it's actually not. It's actually women. So women have the higher rates of mental illness in Australia. So we've got that 1 in 5 stat, you know, 1 in 5, 20%. Women sit just under 23%. And men sit just above 17%. So it's small, but I think what this demonstrates is that there's an enduring myth or misunderstanding around this stuff that perpetuates this idea that men have the higher rates of mental illness, but it's not. It's actually women. And for women, the most prevalent condition is anxiety. So yeah, there's a lot of miscommunication, misunderstanding around this stuff, and some great questions here in the chat box. So this research that was done, it's a little old now, but it was done in such a way that it didn't really require diagnosis. It wasn't based on, you know, Medicare data, things like this. It was a broad survey. Yeah, so there's a few little things that underpin that. I think what we can take away from that, though, is that in the mental health space, there's still a lot of myth and misunderstanding about how it works and what the prevalence rates are and who experiences these things more or less. Yeah, and it's a good reason why doing some development work around this, like you're doing today, is really excellent, because it helps you really get a sense of, a really good sense of how it works and how then you might be able to support people. So let's have a look at depression first. And I think we can all you know, as we all mentioned before, that we go up and down the continuum, we can all probably think about times where we've been sad or low or, you know, moody or, you know, quote unquote depressed. And again, this feeling is normal. This will happen as a result of events that happen in our life and, you know, things that happen to us. We will have periods where we feel sad and low. But depression is much more than this. You know, it's much more intense than that kind of feeling, and it often lasts for a lot longer. And tellingly, it's often the case that people experiencing depression cannot locate a reason for why they are feeling that way. I'll give you a quick example. Last year, a friend of mine had a family member pass away, and this person was very sad, you know, very sad for a week or two. And, you know, this was logical. It made sense that this was happening. It was a deeply sad time in his life. And what I saw when I was kind of staying in touch with him was that he moved from that sort of orange red zone back to the green zone over time, and that was good. If I had have experienced him being so sad and depressed without the you know, pointable event of someone passing away, then maybe I'd be thinking about depression a little more. So depression's much more than just feeling sad or feeling down or feeling low. It's persistent and sometimes has no cause. Yeah, besides the fact that there is depression present as a condition. Now, interestingly as well, depression can absolutely affect both our mental health and our physical health. Yeah, it definitely affects physical health without a doubt. There's a very strong link between the two. It sort of affects how you think about things, how you regard yourself, you know, those sorts of things, and all of that can make day-to-day life really difficult. It can be really difficult for someone with depression to carry on those basic day-to-day things. And so in a workplace, we might see this as somebody taking more leave, more sick leave, maybe being absent more, you know, perhaps not getting things done, those kinds of things, you know, in a workplace setting. And that's not an exhaustive list, but, you know, that's how it might show up. Let's have a look at some of the symptoms. I'm going to pop them up on the screen here for you. Have a read of these and tell me if you see any patterns here, or if you see anything that you think, where does that come from, or how does that fit in? And while you're looking at these, realize and remember that these are not an exhaustive list of symptoms. These are not the only symptoms you might see or that you'll ever see. And they may also not come from a mental health perspective, right? Or come from a mental health issue. So, for example, sleeping difficulties, right? Someone who's having sleeping difficulties, it might be because of a physical health issue, not a mental health issue. Yeah. Moving slowly or sometimes becoming agitated. Again, moving slowly, that may be something physical, not mental health. Yeah. So we can't sort of look at these symptoms and go, okay, well, if this person's got 2 or 3 of these, then yep, that equals depression. Now, it doesn't work this way. It's a much bigger picture view that we need to take about the person. Any questions here about these slides? Let me know. What I find interesting here is that people often think about depression as everything slowing down, being less, being quieter, being slower, but it can be the opposite as well. So for example, they're moving slowly, or sometimes they're so agitated they can't settle. Yeah, that agitation state, sometimes people don't associate that with depression straight away, because we're used to seeing depression depicted in a certain way as being sad and down and, you know, all of that sort of thing. Same thing with the sleeping. Sleeping too much or sleeping a lot might be seen as a typical or, you know, stereotypical kind of symptom, but also they might be sleeping too little, yeah, or not able to sleep. Pratap says continuous fatigue. Yeah, fatigue might be one of them. Yeah, absolutely. But I guess too, like I was saying before, we can't sort of say, oh, this person's fatigued, so therefore depression is present. So a lot of the time we see these signs and we see these symptoms, and we actually need to have a conversation to work out with the person whether or not it is actually coming from depression, or if it's coming from anxiety or coming from some other place. We need to have that conversation. I'm going to show you how to do that. So these are the kind of common symptoms of depression. You know, and again, not exhaustive. and not prescriptive either, not a checklist at all. There may well be other signs and symptoms that we see within the person. So let's have a look at anxiety. Anxiety is actually the most prevalent mental health condition in Australia, and with women sitting at, I think it's just under 18%. So it's quite prevalent, anxiety. And again, we have this concept in mental health, and particularly with anxiety, that some anxiety at the lower end of things can be almost constructive, almost useful. But when it's not useful, this is when we start thinking about it as a problem. So for example, if we have a deadline that we need to meet and we've got that kind of energy from that anxiety of like, I've got to meet this deadline, I've got to get this work done, and it's just in the right balance, it's in the right proportions, then that anxiety can actually spur us on to perform at a high level. Yeah, it can actually get us to hit that deadline, meet those targets and that kind of thing. But where anxiety is present and there isn't that need for it, that's when we start thinking about, anxiety being in the mental health space or the mental illness kind of space. So it's more than just feeling stressed or worried. Yeah, as we were saying before, stress and worry and being anxious is a normal kind of thing. We all experience these sorts of things. Yeah, we all do. If you haven't felt anxious about something before, I'd be really surprised. Yeah, I'd be really surprised. So, it's just, it can be a tricky one because sometimes anxiety is, like I said, useful, or it might be relevant, or it might be, kind of acceptable to be anxious in certain situations. But again, what we're looking for is, are these anxious feelings staying and persisting, or are they going away over time? Is there something that's causing the anxiety? Is there something that's not? These sorts of things. But when it's at the more serious end, anxiety is a really serious medical condition that makes it really difficult for people experiencing it to get on with daily life. It gets right in the way of all of that sometimes. So, Anne says it's important to distinguish anxiety from stress. Yes, these are two separate things. They play in the same space, I like to say. Stress can lead to anxiety, for example. They can exist separately, they can coexist. Yeah, absolutely, it's different. And people will talk about anxiety, they'll say, oh, I'm really anxious about something, when they're really describing that they're stressed, and vice versa as well. And it says in the chat box, one definition is that anxiety has a physical component, whereas stress is contained within the cognitive realm. Yeah, that's an interesting way to think about it. Yeah, absolutely. So signs and symptoms of anxiety are quite broad. Let's have a look at the physical ones. Yeah, so these are some of the physical ones. You'll get that those classic ones, pounding heart, rapid heartbeat, blushing, feeling hot, maybe feeling dizzy, headachy, sweating. In terms of breathing, the person might be really short of breath. Yeah, they might have a sensation of a dry mouth, or being nauseous, or a choking kind of feeling in their muscles. They may feel aches and pains. They might be shaking, trembling. This kind of symptom we might observe. And so with anxiety, we have the physical symptoms, which can be very similar to other conditions like a heart attack. They can be similar to things like stress, these sorts of things. But if we balance them out with the psychological and the behavioral, this is often how we get a bit of a better sense about, is this anxiety or not? So from a psychological perspective, and as is mentioned in the chat box, unrealistic or excessive fear or worry. Yeah. So where there's fear or worry about things where there's no need to be fearful or worried about, that kind of thing, or where the worry or the fear is excessive. In terms of the mind racing, that can be certainly like with depression. It can be that the mind races ahead, a million miles an hour, or it could be that the mind goes blank. Yeah. So it can have all of these different types of presentations, and everyone's experience of anxiety and depression and any other mental illness is all very different, but they all have a common kind of feel to it. From a behavioral perspective, you might see them being really obsessive or really compulsive about a certain thing or an action or a behavior. They may have a phobic-based anxiety, so they become phobic of certain things, the classics, fear of spiders, fear of going outside, fear of birds, this kind of phobia type thing. Social situations might also be an anxiety type. So, or I should say, social anxiety is a type of anxiety where people don't want to be in social situations, whether that's just with people or in a socializing kind of setting, and so on and so forth. So, there's lots of signs and symptoms of anxiety that we might observe. But as you're probably getting a sense of, it's important to make sure that we take a bigger picture view of the person, what we know of the person, how long things have been going on for before we actually decide that the person is experiencing anxiety, or that we think that they might be. I mean, we can't diagnose it, right, as leaders and managers, unless we have those skills and qualifications. Certainly mental health first aiders are more able to get a bit of a read on that, to make an assessment of it. But we can't assume with mental health and mental health first aid, we can't assume what's going on for the person unless we absolutely know. Some questions here. Beverly says, can anxiety be an ongoing thing from a previous difficult work situation? Yes, it could be. Anxiety can be something, if someone has a anxiety condition, anxiety might be present 24 hours a day, 7 days a week about any particular thing. Yeah, so it gets sort of like if someone has a really, a physical condition, and they experience that physical illness or that physical sign or symptom constantly, maybe like a sore knee or something like this, same sort of thing. So anxiety can persist on an ongoing basis, but it can also be amplified by certain events, and recalling and reliving certain events as well. So it can be ongoing, absolutely. Yeah, it can be ongoing. Rowan says, anxiety is anticipatory stress, unknown outcome. Yeah, so yeah, absolutely. These are the ways to think about it. And I guess as well, it's really important for us to realize and remember that we're not qualified to make these diagnoses or anything like that. So from a mental health first aid perspective, what we learn is that we want to see the signs or symptoms for what they are, have a supportive conversation with somebody about it, and then get them connected to a professional. Pratap says, will you be covering performance anxiety? Not specifically, no, not today, but happy to have a conversation with you afterwards. So lots of people will tell us, and in conversations I've had with people, certainly, they will say something like, I've got a gut feeling that something's not quite right with my colleague or with my friend, but I don't know if I should have this conversation. I don't know if I should bring it up. I'm not sure. And so this can be for two reasons. One can be that we're not sure that there is a problem in the first place. And then the second reason might be some nervousness around actually having that conversation. So to work out when we should be concerned, because remember, everyone goes up and down the continuum, that mental health continuum. When should we be concerned? There's three main parts to this. One is, has this person experienced a major change in the way that they think, or the way that they're behaving, their behaviors, or the way they're feeling? Yeah, is there a major change to this? And this is where I think as coaches and leaders and managers, we're in a great position because we often know our people really well. So we're primed to see this shift. We're primed to see this change in people. And often it can be really subtle, but because of the rapport we have with the person, we're able to see that subtle shift. And that can be enough to actually have this conversation and support that person. So we've got this shift in their behavior or something about them, the way they're feeling, thinking, behaving. The second bit is how those changes are affecting that person's ability to do what they normally would. So whether that's at work, at social life, family life, home life, whatever it is, these changes that we've observed, are they having an impact on the person's ability to do what they usually are able to do? So in the workplace, it might be that someone's performance is lower than it usually is, or a particular task that they normally do, they're not keen to do, or they don't do, or they can't complete. Whatever it might be, we're looking at how much impact are these changes having on their ability to do their normal kind of day-to-day life. And the third one is, if these changes that we've observed and the impacts that they're having last longer than we expect them to, or if they don't go away quickly. Now, the coaches in the room are probably going, what does quickly mean? Give me a definition for quickly. We want to know what quickly means. And in this space, we're thinking about a kind of a two-week window, 2 weeks or longer. But it doesn't mean we can't have a conversation with somebody before that 2-week period has come around. We can absolutely do that. There's no harm in doing that. So for example, if we notice a major shift in the person's behavior and it was really intense, it was having a massive impact on that person, then we probably wouldn't wait 2 weeks to jump in to have the conversation. Yeah, but if we see little shifts and changes and the impact is not that big, we might hold off and just stay connected to the person, be supportive, and get a sense of if that needle starts moving back towards the green part of the continuum. So these are the 3 things we think about. Do I have to be concerned here? Do I have to have this conversation? Should I have this conversation? Yeah, these are the 3 kind of levers that we're going to play with. Now, of course, we know that 65% of people don't get that assistance that they need. And a big part of that is because they feel a lot of stigma about what they're going through. And in that sort of state, in that sort of stigmatized feeling, people aren't really forthcoming about opening up to talk about these things. So we need to be comfortable to actually start these conversations. And that can be nerve-wracking. It can be can be difficult. It can make us feel nervous. It can make us feel maybe a bit anxious about doing this. So who here, let me know in the chat box, who here has had these sorts of conversations before and how do you feel about it? When we go through the mental health first aid program, we learn a particular model here for how to have these conversations and how to make all of these assessments, I should say, about what's going on for the person. And I guess the thing I want you to know is that even without those mental health first aid skills, which I think are important for everybody to have as leaders, but even without those, there is some stuff we can cover off that hopefully makes you feel a lot more comfortable about actually having the conversation. Because I find oftentimes people are very positively intentioned, and it'll be something like, I think there's something going on, but I don't want to make it worse. I don't want to offend the person. I don't want to, I don't want to make it worse for them. I don't want to butt in, so I won't have the conversation. But what we know is that actually going the other way and using that kind of that sense making that we do to have the conversation is the better outcome. So to help you feel comfortable, here are a few tips. So we don't always have to be having full-on conversations about, hello there, I've got a concern with you about your mental health and I just want to check in with you. It can just be a simple, how are we all going today? You could put up the continuum and just say, where is everyone on the continuum? We could say, out of 10, how are we all feeling from a mental health perspective? We can just talk about it. We could just say, if you've got people coming back to the office and they're a bit nervous about it, we can just check in going, how are you feeling about being back in the office? Just these sorts of little check-in conversations create an environment in which people feel comfortable to talk about this stuff. And so then when we have to have a conversation with someone, they're kind of ready. They know the intention is positive and they're probably more likely to have that conversation. And as I was just saying, as workplace pressure mounts for some people, particularly as we go back to the office and we start working back in physical spaces, we really need to look after ourselves and other people. So if you do notice these changes, if you do notice behavioral shifts or physical changes or any of these sorts of things, you might use some of these words in opening up the conversation. You might say, I've noticed a change. I've noticed that, you haven't been to the office for a couple of weeks now, and I just thought I'd check in with you, something like that. Or something, I really care about you and I want to make sure that you're well supported. Can I ask you some questions? Yeah. I'd like to help. Would you feel like having a conversation? Can we have a conversation? Yeah. So these are some opening kind of lines for how you might start the conversation. And these are ones that we learn are a good way to have this conversation when we do mental health first aid. And know as well, the research is really clear. People with lived experience, so people experiencing these issues, welcome positive, respectful inquiry that's empathy-based. So if basically, summary, people with lived experience want us to ask. They want us to check in with them. And we can't make someone's mental health worse in the long term by asking about it. You know, they might feel a little bit of anxiety or a bit nervous or a bit of stress at the time because it's an awkward conversation, but we can't have a significant impact on their mental health in the long term by asking about it. Quite the opposite is true. So we've just hit 12:30. I want to show you these two programs. We have our Leader as Coach program and our Mental Health First Aid program as well. If you haven't done Mental Health First Aid, I really encourage you to have a look at that on our website. It's a great little program, and there are some people on the line here who have done it with us, which is really great. And our Leader as Coach program as well is a really good one to have a look at too. A little 2-day coaching 101, basically, how we do coaching. Let me answer some of those questions. Rowena says, I have these conversations a lot with clients and friends, and Pratap says the same sort of thing. Carol says, I think it's a tricky conversation because you don't want to offend, overstep the mark, or even put thoughts into someone's head on things that aren't there. Yeah, that's true. I guess know that we're not going to put things into the person's head. That's another kind of myth that we cover in Mental Health First Aid. Rather, we flag to the person that we care and that we want to help them. So feel confident to have it. And even say something like, you know, I don't mean to offend you, but I want to ask about X, Y, and Z. Just naming it could be very useful as well. Beverly says, I've had a series of conversations with one team member, and she disclosed to me she was suffering from anxiety. We now have a great relationship, and I'm supporting her and referred her to a counsellor. Amazing. That's awesome, Beverly. Well done. Yeah, well done. Rowena says, noticing and inviting the conversation definitely helps. Seen and heard. Yes, absolutely. Seen and heard. Yeah, just gently inquiring in a respectful way, saying, you know, I've noticed a few changes, or I've noticed something in particular. I just want to check in with you. Do you mind if I ask you how you're going from a mental health point of view? These sorts of things. They don't have to be, interrogatory or too confronting. We can do it nicely and in a sort of nice, soft, warm way. So thank you, everybody, for attending the session today. My name is Nick from Open Door Coaching. This has been our coaching cafe this Friday. We'll get the recording up on the blog, and we hope to see you on another cafe sometime soon. Thanks, everybody.